Good morning from WFLHCA. Hope everyone is doing well. We'd like to get started talking about our mystery case for the day. And here's Sherlock Holmes, who's looking at a nice example of atrial flutter with sawtooth waves, rate of about 300th atrial rate, and variable ventricular response. And so atrial flutter, a flutter mystery case. And so let's talk about this case for a very minute, because it's kind of interesting, and some of the interesting things will come out as we discuss. So let's proceed. So this is an 86-year-old, and I don't think she's windowed, I think she's really widowed, but apologize for being windowed, and we can change that real fast. And there we go. And so she's a very nice lady who has recently had some shortness of breath for several weeks, which she developed during a 14-day cruise to Norway and Sweden. Looking at her activity, I'm getting short of breath just thinking about it. Prior to that, she went on a cruise to Costa Rica. Not the same thing as an air flight in terms of inactivity, because she's very active. When in town, she rides her bike daily. She is a cigarette smoker and continues to smoke with a 50-pack-a-year history, a history of chronic bronchitis with daily cough a couple times in the morning. She had a cardiac cath for some reason 12 years ago, which she said was okay. She presented to the emergency room in St. Joseph's Hospital in atrial flutter, just like the little rhythm strip that I showed you. She was called CHA2DS2-VASc 3 by her age, being over 65, being over 75, and then female, gave her a 3. She was diagnosed as having pneumonia. I'm not sure what the data was for supporting that. She denied fever. She denied chills. She did not have an elevated white count or a shift to the left. She did have chronic cough, which she's had for years. She had an increased D-dimer of 1,277. And so she had a negative D-dimer, essentially rules out pulmonary emboli 99% of the time. Her B-type natriuretic peptide was 3 to 400. I think it was about 333. Troponin was negative. Atrial flutter, the drug chose was amiodarone for rate control, as well as some low pressure for rate control and for converting to a normal sinus rhythm. Hopefully, she was discharged home on these medications. I don't know the results of her echocardiogram at that time, but she was readmitted 2 weeks later, still in atrial flutter, with a controlled ventricular response. At that time, since she didn't convert, the amiodarone was discontinued. Creatinine was 1.1, so she could have a CT of the chest, rule out pulmonary emboli because of the elevated D-dimer. She had an echo report. I don't have the echo, but the echo report said left atrial moderately dilated, but measured 28, which didn't make sense. So something was wrong with one of these. Moderate mitral regurgitation, posterior mitral valve leaflet prolapse, mild to moderate TR, complained of fatigue. CHA2DS2-VASc 2 was 1. So this is the CHA2DS2 was 1, CHA2DS2-VASc was 3. Everyone, I think, is using the CHA2DS2-VASc now because it seems to be a superior prognosticator in terms of predicting pulmonary, in terms of predicting patient's going to have embolic episodes, that is, i.e. stroke. And so it's a better predictor. CHA2DS2 has been mostly abandoned, but was used in this case and was listed as 1. She was treated with aspirin then, being defined as CHA2DS2 1. Pulmonary function tests were normal. EKG, right bundle branch block, right axis deviation, atrial flutter. She was treated with ProAir, Symbicort, Spiriva, which she did not tolerate well, and hated the medications because it made her very nervous. Increased her atrial fibrillation, atrial flutter, increased her atrial flutter. So she had a TEE cardioversion to normal sinus rhythm. While on Rhythmol, which she was on a maintenance dose for some time and was put on Eliquis, she converted to a normal sinus rhythm. Because she converted, we had an opportunity then to do a coronary CT, which we did while she's in normal sinus rhythm. She did go back to atrial flutter later and was a Rhythmol failure. Her TEE showed a very large left atrium, normal ejection fraction, increased right atrial size. Tricuspid valve annulus was 38, which is a measurement that's used for cardiac surgery to decide whether someone should have a tricuspid annuloplasty or tricuspid valve replacement. And so we'll get back to this later. She had increased RV systolic pressure. It wasn't high, it was only mildly elevated. Rhythmol was discontinued since she was a Rhythmol failure. She was started on Multac plus Renexa and converted chemically to a normal sinus rhythm. But while in normal sinus rhythm, she still complained of severe fatigue, unable to ride her bicycle. And so she did get an echocardiogram in the office. And we also have a CT to show you. I don't think we can show you the TEE cardioversion because we have to go through this long process of getting back through into the HPAC of HCA Healthcare, and the steps are so complex. I couldn't hold it there because they don't let you minimize the screen. You've got to log out, so I had to log out. It's so complex to get through that. Suffice it to say that these were the findings, and we will move on. So let me show you her office echo. Okay, so here's her office echo, which shows the left atrium was enlarged compared to her aorta, which this should be the same size. Left atrium should be the same size as the aorta, and you can see it's much bigger. And then we're watching her mitral valve. And it's sort of in slow-mo, but the posterior leaflet is going posterior, and by going posterior, it's leaving a gap between the anterior leaflet and the posterior leaflet. We'll stop it and show you the gap here in just a minute. And right here is the posterior leaflet going back like this. The anterior leaflet is staying here, and the gap is right through here. So that should be the area that shows mitral regurgitation. Let's proceed some more here. Left atrium is markedly enlarged. Should be the same size as the aorta. Starting to get some color on the right side. And so you see tricuspid regurgitation. The aortic valve looks great. There is some calcification in the aortic valve, but minimal. And what's interesting is the lack of calcification in the mitral valve annulus or the mitral valve. And when you look at this valve and the filamentous gossamer appearance of the posterior mitral valve leaflet, when you look at that, here's where it's failing to coap. When you look at that, it looks like what you might see in a young person, certainly someone ranging from anywhere from 18 to in their 40s, with no calcification, no mitral annular calcification, very nice leaflets, and it looks like the only problem is that there's probably some stretched cords or broken cords, and so we've got like a flail posterior mitral valve leaflet. Let's see if we can get some color on this. And there was, take my word for it, severe mitral regurgitation. This particular sequence isn't showing the color, but we may get to it in a minute. And here again, you see anterior leaflet is in a great position, but posterior leaflet has gone posteriorly and has this sort of scallopy shape and leaves a gap between the two leaflets, providing for mitral regurgitation. And it's just a very, very beautiful example. And there's the tricuspid regurgitation on the right side, as you can see, with a large right atrium. And that looks like 2 to 3 plus. The RV systolic pressure was elevated. It was like in the 40s. And let's go back this way and see if we can see the jet. Ah, here we go. And here's our jet of mitral regurgitation coming right through the area that you would suspect that there is a gap, and having a wide vena contracta and going posterior to the left atrial wall with some regurgitation perhaps in one of the pulmonary veins here. So severe mitral regurgitation, enlarged left atrium, RV systolic pressure elevated, tricuspid regurgitation, annulus of 38, right atrial enlargement, normal right ventricular contractility, normal left ventricular contractility, all the hallmarks. This is normal sinus rhythm at this time, right bundle branch block, right axis deviation, history of recurrent atrial flutter, failure to keep the patient in their normal sinus rhythm, even with aggressive medical treatment after cardioversion. Failure for the patient to improve after cardioversion because of severe mitral regurgitation. And here's our RV systolic pressure over here. There's the a measurement, 6.8 pixels. Let's go back this way again. Minimal elevation of the right ventricular. This is on the left side. There's minimal elevation of the right ventricular systolic pressure. Wide open mitral regurg. This is a great way of looking at it here. Hang on. And you can see several jets all coming out of the same area. Severe mitral regurgitation. But really a nice looking valve. Very unusual morphology of the typical characteristics seen in patients that are usually a lot younger. An 86-year-old lady with typical characteristics of mitral valve abnormality that's repairable. It's very unusual to see that in this age group. Here's our 3D image. More observations. Subcostal, subxiphoid view looking at some dilatation of the inferior vena cava and large right atrium. Right ventricle has good contractility. Right ventricle is doing well. Left ventricle is doing well. Should be hypercontractile with this amount of mitral regurgitation. So let's go back. Hang on. And we'll go look at the next image. Hello, Largo Medical Center. We're presenting an 86-year-old lady who has, and I'll reiterate for just a second, 86-year-old widowed female, 14-day cruise to Norway, cruise to Costa Rica. When in town, rides her bike daily, 50 cigarette pack years, chronic bronchitis, cardiac cath, normal in the past, presented with atrial flutter, and which was resistant to amiodarone, had left atrial dilatation, moderate mitral regurgitation, some prolapse posterior mitral valve, treated because she's a smoker, not tolerating these drugs, and had these findings on TEE and the office echo we just showed. Now we're going to look at the CT. And this lady has not improved with the management that she's been given, which the management she's been given has basically been getting her out of atrial flutter and finally getting her out of it successfully, but being left with mitral regurgitation, which has been severe. And we're back to looking at her cardiac CT. So we rushed to get a cardiac CT while she was still in sinus rhythm, not knowing if she was going to stay. You might ask, well, why would you do that? You know, are you looking for pulmonary emboli? And actually what we're looking for is we want to find out what her coronaries look like. And we want to know that because we're thinking she might be a candidate for mitral valve repair. Well, you usually don't see that in this age group. However, the first mitral valve repair that I sent for robotic mitral valve repair, which was maybe 12 years ago, was a lady who was in her 80s, who was the mother of a cardiovascular surgeon. And so that was really testing Dr. Chitwood's skills when he was the surgeon of choice at East Carolina State University, and he had a cardiac surgeon breathing down his neck in the operating room while he operated on his mother. So we're looking at that with consideration, and perhaps she's a candidate for mitral valve repair. And so we thought we'd take a quick look at her coronaries, and by doing that we can avoid cardiac cath if she has reasonable coronary arteries. And she does have coronary arteries that don't look so bad. There's a little calcific nodules here and there, a little area of fibrosis here, but overall there's an artifact here. Overall, she's got pretty good looking coronaries. Let's look at her right coronary. These are looking pretty good to me. And so if we can show normal coronaries, and if we've got a great TEE, which I haven't been able to show because I have to get in the HPAC to show that, and if she's got a great TEE, normal coronaries, then we don't really need a cath. Let's take a look at her circumflex. Circumflex looks good. It didn't follow out all the way, but we can find out more about it distally looking at some other images here in a minute. So let's go back and take a look at her left atrium while we get this opportunity. Well, here's the left atrial appendage up here, and it appears to be clean. So that's a good thing to know from the TEE as well as from doing the cardiac CT. Here's her pulmonary valve, which looks good. We're looking at her right atrium here, right ventricle here, left atrium over here, aortic valve, and there's her mitral valve. Left ventricle. Let's look at some more of our images. This is invaluable to find out more. Here's her mitral valve. You can see it pretty good up here. Probably a broken cord. Right in here somewhere, a broken cord, failure to coap, posterior leaflet going too far posteriorly. Anterior leaflet looks pretty good. Left atrium is very large. So this has been active for a while. Atherosclerosis in her descending aorta, but not much. Osteoporosis, as you would expect at her age, even though she's very active. Pulmonary arteries look okay. Don't see any pulmonary emboli, even though the D-dimer was elevated a little bit. Lungs are a little hyperinflated. Diaphragms aren't really very flat. Take a look over here for a minute and see what else we can find out. Here's your very familiar axial view, where you can see the mitral valve leaflets, anterior and posterior. They don't have to coap right now because this is diastole. This left atrium is large, and we can give you a quick measurement here. Let's drop down from here and see what size. Well, it's 44 or greater. We can go over here and we can cross the right atrium. We can cross the left atrium. It's big. Right atrium's big. Right ventricle's not bad. Lungs are not bad looking. Aorta isn't bad looking. So normal coronaries is what we came here for. And so that shows up pretty good. Let's see what else. So let's go back to our slides. And what other test would you do? Does she need a cardiac cath? Do we need some right-sided pressures? I'm pretty happy with the information I have. Does she need coronaries? I don't think so. I think we've got some pretty good images. So here she is in normal sinus rhythm now, and not guaranteed that's going to last very long given that left atrial size and the right atrial size as well. It could be right atrial flutter, probably is, rather than left atrial flutter. Usually you can see from looking at the flutter waves where they're originating from and how they're traversing an atrium and determine right from left. What are we going to do with this lady? Are we going to radio frequency ablate her flutter when it comes back? How do we get her back on her bicycle? How do we get her back traveling? Well, how about mitral valve replacement and tricuspid valve replacement at Pepin Center where she lives out there? And so she's considering that. How about mitral valve repair in an 86-year-old lady, not well thought of, not well heard of? Tricuspid valve repair too, with maybe shoring up the annulus with a ring, with a maze procedure, or maybe just flutter ablation. How about a mitral valve clip? Well, that's not a central leakage. It's a leakage that's going off to the side. I don't think it's going to clip well. How about continued medical management? Well, I mean, what do you do for mitral regurgitation? Diurese her a little bit. Doesn't have edema. She doesn't have right side edema or left side edema. How about robotic mitral valve repair, tricuspid valve repair, left atrial exclusion and maze? How about robotic mitral valve repair, left exclusion and maze without touching the right side? Because you touch the right side, you just increased mortality risk at least 15 or 20%, maybe more. Any suggestions? Mary Daniels, got any ideas about this one? This is a tough one. You don't see ladies this age having mitral valve prolapse. Well, let's show exactly what happened. And so the next slide shows discharge from the hospital on day 3, no transfusions, and walk to the car. Well, any ideas at Largo? Melody? How could she on day 3 be discharged from the hospital, no transfusions, and walk to the car? Well, let's see. That would be maybe right atrial ablation of the isthmus for atrial flutter, right? Could be. Let's go see what happened. Robotic mitral valve repair was first done by Dr. Didier Lumet in 1998 with Dr. Alain Carpentier in Paris, France. Does Dr. Didier still do this work? Yes, he does. And actually, he did her mitral valve repair. I don't know how many he's up to now, maybe 500, 600, and is the current ranking #1 experienced mitral valve repair doctor at New York University in New York City. And so we persuaded our sweet little lady to go up there and get that done. So let's look at her post-op follow-up echo. So hang on and we'll find her echo. And so that takes us to yesterday. Let's open this up. Let's see if we can load this one. There we go. Let's play this. Well, as you can see, her mitral valve is now coapting. The posterior mitral valve leaflet is no longer collapsing and going posterior like it was. The right side still has tricuspid regurgitation, so we'll say that the right side hasn't been repaired or replaced. And you can see there's nice mobility of both anterior and posterior mitral valve leaflets. Absolutely no mitral regurgitation. Left atrium actually looks smaller already starting to remodel, which is very dramatic. Looks like the same aortic valve, looks like the same lady, but no mitral regurgitation and left atrial remodeling that's already begun. Does she still need treatment to keep her out of atrial flutter? Well, I continue her on Multac, so which is half a drug, Renexa being the other half. And yes, she still needs that. And there's just a puff of mitral regurgitation. This looks very good. There's a right bundle branch block. And excellent results of a repair. And you can see she's in normal sinus rhythm. There's her P wave. There's a QRS with right bundle branch block. Normal sinus rhythm. Excellent repair. We still have the right side to deal with. Well, given a 15 to 20% increase in mortality, if we touch the right side, it seemed to me that with a tricuspid valve annulus of 38, as we measured on the CT scan, that side should recover, and it takes a while to have decreased RV systolic pressure. Usually there's a decrease immediately post-op, but it takes a while to get back to normal and to get remodeling of the tricuspid valve, right atrium, and right ventricle. So she still has an elevated RV systolic pressure. Some of that should improve dramatically in a short period of time, out of the hospital at day 3. So a good case for mitral valve repair in a lady who is 86 years old, and there she is. And she gave us permission to show her picture today. So we would show you that she's ready to get back on the bicycle pretty soon. She's got a couple small little holes near the sternum for insertion of the arms, and then a little right-sided area for taking out sponges and stuff that's a little scar. And so it feels pretty good, has clear lung fields, and normal sinus rhythm back on Multec. So we just wanted to show you this as a very interesting case of a lady who is our mystery case of atrial flutter, that sometimes getting rid of the arrhythmia is very difficult, and sometimes getting rid of the arrhythmia does not result in satisfactory results in someone. And you can see all the options that we had, but we didn't touch the right side, because touching the right side is an increase in mortality, and it's not worth it, especially robotically taking some risk with robotic surgery, because you're not used to doing right-sided repair. The whole team is used to doing only mitral valve repair, and extending into the right side may not be a good idea. So that's our case, and we have a couple of other things to talk to you about, but just hang on for a minute, and we'll close this up and reduce this, and come back over here and exit this. And we were going to show you, we wanted to rework a case that we talked about before, and show you how it might work out with 3 different scenarios. And so we've talked about our new model for perioperative evaluation of patients who are getting orthopedic surgery, pelvic floor surgery, or common surgery like hernia repair, and how we're approaching those patients who basically are in the same demographics as my heart patients, many of them actually being my heart patients or being asymptomatic and coming in and perhaps being my future heart patients. So let's look at how hip replacement normally plays out, and what the scenario might be. And so we have this gentleman here that we're going to show on how it plays out, who's a 62-year-old guy that we talked about before, had atrial fibrillation 12 years ago, no known coronary artery disease, normal EKG and echo, low risk for hip replacement, case number 12 of 15 in room 3 by Dr. B. And so looks like, hey, no big problem. And so disaster. Post-hip replacement atrial fibrillation, stat cardiology consult, management with diltiazem and amiodarone, develops severe chest pain, diaphoresis, acute anterior wall MI, emergency angioplasty and stent, bleeds into the hip from blood thinners, prolonged hospitalization, move to rehab, $1 million or greater in medical charges. So how do we go wrong on this gentleman? Sound like a pretty fair evaluation. Well, let's go look at other cases and talk about this, because I think this is a more common happening than you will believe. And so here's a gentleman that's actually in my practice. He's a 77-year-old married white male who had right hip replacement 8 years ago without problems. Piece of cake, just ran through it. We're really happy with him, and now he's facing the prospect 8 years later of left hip replacement by the same doctor at the same hospital. And hey, he's 8 years older. Well, he had the same history he had before. He had an acute anterior wall MI in 1984 with LAD occlusion with angioplasty, recurrent event in 1993, LAD atherectomy. In 1993, he had a large diagonal vessel that was patent but had a severe stenosis, and so he got angioplasty at that time without problems. And then in 2005, he had a coronary CTA, which showed pretty much the vessel D1 was doing well. The LAD was totally occluded. The anterior apical portion of the left ventricle had calcified, and basically it was not aneurysmal, just calcification, no remodeling. and he looked like he was doing pretty good. No progression of coronary artery disease. Ejection fraction around 40% on echocardiogram. And then he had another coronary CTA, 2014. Seemed reasonable. 9 years later, let's see how he's doing. And you know, I've done a lot of serial coronary CTAs with follow-up on patients. Radiation was low, about 3 millisieverts. And we looked at it, and everything looked pretty good there as well. He did have no evidence of progressive coronary disease. He has bilateral lower extremity lymphedema, which has been a problem with saphenous vein ablation on the left side in the past. History of hypertension, diabetes, which is mild, obstructive sleep apnea. Recent attempt at weight loss, which was excellent. He lost 20 pounds, looked a lot better. And the surgical risk. What would you say this gentleman's surgical risk is? Well, we thought it was pretty low, but that's before we started our new program of evaluating patients to see exactly what the risk is by quantifying much more detailed information. Perhaps a 24-hour Holter monitor looking for atrial fibr flutter, which we found recently. Perhaps certainly an echocardiogram that's recent to look at the left atrial size and to look at the valves and look at LV dysfunction and look for a new area of wall motion abnormality and also compare the strain echo. So certainly more options to find out more about people like this. Are those smart things to do, or are we just sort of working the system a little bit? Well, let's look and see what happened to this gentleman and find out if this was a fair assessment of him. And so surgery, left hip replaced. 3 cardiology groups came to see him post-op and argued who would be his doctor. He got very upset over these 3 groups coming in with massive white coat followings of lots of people, and basically whether that played a role in his developing post-op atrial flutter, I can't tell you, but he did develop atrial flutter and had to have his ventricular response controlled. May have gotten some blood thinner at that time. However, 9 days post-op, his wound dehisces with significant bleeding. What caused that? I'm really not sure. Infection couldn't be traced. Antibiotics were given, but cultures revealed no active contaminant found or no active septic organism. He did develop DVT in the left lower extremity, had to be treated with Coumadin. He was immobilized for a continued length of time. Of course, he had IND surgery, and now he's going to be on Coumadin for 6 months. Infectious disease says he'll be on doxycycline indefinitely. So, well, you know, I would say this was quite a disaster, and I'm not sure what we could have or should have. Should have, could have. It's good to say, but certainly these patients are candidates for atrial fibrillation, and let's go back to our other case and continue to discuss options and what happens to people. And so we have this new program of orthopedic surgery, pelvic floor surgery, hernia repair in seniors, same demographic group as my heart patients, that we're doing and looking at a lot more extensively than we had in the past. And certainly one of the things we're looking at is we're looking at heart monitoring, because so many patients with paroxysmal atrial fibrillation flutter, we have people with pacers, we have people with ICDs with histories of VT, we have hypertension, hypotension. Of course, hypertension, as you get older, hypertension is more common. As it becomes more common, atrial fibrillation becomes more common. 15% incidence of atrial fibrillation in this age group. Hypertension, certainly maybe 65, 75% patients having hypertension in this age group. In the past, we had Albert B., who was on Plavix, waited 5 days off of Plavix before surgery and bled into his hip and died. We decided to start sending patients to Tampa General. Tampa General, they get in the assembly line, number 12 of 15, bleeding in rehab, discovered by a general practitioner, not by the PA making rounds. have not been seen by orthopedists for a couple of days, and so another trouble, and then clotting, pulmonary emboli, more problems, acute coronary insufficiency, and we look at her hips. Current patient we're talking about again, about what would happen and what are the scenarios, and we presented one scenario of what would happen in the real world, not like unlike the gentleman I just showed you in terms of real world pathology. We got Gary, who's going to have his shoulder, has protein C deficiency. We got Patrick, who's going to have his knee, has a pacer, has a history of VT. We've got these pelvic floor people. We've got this lady we're working on right now who has had a CVA recently, has a mitral valve repair in the past, paroxysmal atrial fibrillation, maybe, antithrombin 3 deficiency, protein C. We got a patient with pelvic floor who has hypotension from neurocardiogenic syncope. We got hypotensive last time she had surgery. We got another patient with pelvic floor with paroxysmal atrial fibrillation is back in it, recent CVA. We got another patient with DVT, use of Revlimid and Decadron for myeloma, and has a family history of DVT and 100% risk of getting DVT post-op. And then we have the hernia repairs, and here's somebody with paroxysmal atrial fibrillation who shoots their blood pressure up to 200 systolic, 220 systolic when he's off his blood pressure medications. And here's a guy who has apical hypertrophy and gets very hypotensive, especially if he has to wait, 12 hours NPO to get his surgery. And so these patients present varying complexity that has to be sorted out, I think, in more detail than we have in the past, as witnessed from the previous patient that I showed you. So let's go look and see what we could do on the current patient who was sent for pre-op evaluation for hip replacement, found to have asymptomatic recurrent PAF, which was just picked up. We just put him on a monitor and found it, treated him with Eliquis, propafenone, cardizem, and we took this out as a perioperative event by basically saying, okay, we'll give him just a few medications with sips of water before his surgery so we can have propafenone and cardizem on board. And we stopped his Eliquis, of course, appropriately within a couple of half-lives to make sure that it was resolved as an issue. And then we did a coronary CTA and discovery of asymptomatic coronary artery disease with ruptured high-risk plaque. So let's talk about this. This is something we've talked about with OACE when he was on our service over here. And here's our 63% stenosis. And here's a very complex plaque, which you can't see exactly the details in here, but looking at this and looking at this, and then there's not only is there in this indentation, but there's a little area of ulceration inside the vessel, and this is sort of something that's occurring within the wall. There are many things that are occurring within the wall, some fibrosis, some necrotic core, as well as a little ulceration within this wall. So this is a very complex, and here's the ulceration. You can see it right here. See this little outpouching that's seen on this column of dye that's representing the lumen. Right there is a little outpouching area that represents an ulcer within this. This is not calcification. There is calcification upstream. Here you can see this paler yellow is actually a bleed, a pigment, so to speak, of the green and the blue producing yellow. And so this is really not what you think it is, which is calcification, which is a much different color yellow. And so this is just an artifact produced by this particular software vendor. So, okay, I'll look here. There's another little lesion found here that's in the posterior descending, and that's interesting. And it's got a convergent divergent double cone, which you'll find is same as a rocket nozzle, which produces eddies and vortices. And looking at our CTE MPI, after nitroglycerin in contrast, there's two areas of decreased iodine in the myocardium. And looking at our coronary strain, our cardiac strain echo, there are also two areas of decreased mechanical function of the left ventricle. Ejection fraction is normal, but there's decreased mechanical function. And then let's look at the other thing we did. we actually post-processed the left ventricle and color-coded from vital images to software to get the amount of myocardium that's subtended by this left anterior descending lesion, be able to actually weigh it and give you a volume and a size of this in order to be able to calculate something called FMM, which is represents a myocardial mass analog to FFR. And this is myocardial mass as opposed to fractional flow reserve. This is fractional myocardial mass. And so we have a formula that we can use that's from Dr. Kim, who's in South Korea. There's also information from Dr. Ko, who's in Australia, about how we can use a system and plug in myocardial mass. But of course, what they're doing is Dr. Kim is using an allometric way of producing this information, which is a computer model, and Dr. Ko is using a Calgary program that compared CT to MRI, and you estimate the distribution of left anterior descending and look up on the table how much myocardium you think is subtended. And so this gives us much more accurate than Ko or with Dr. Kim. And so we're able to tell exactly what the FFR is. And this patient has reduced FFR by our calculations in the distribution of the left anterior descending without getting heart flow to get information from heart flow. And so let's look at this and see what happens during knee replacement. And of course, nobody knows this, but if you go in the OR and you look and see, you're going to see fat bone cement fibrin, which is very active in Hagman factor type activation of platelets to produce extremely active platelets and an inflammatory response, which is going to head right for that area of ruptured plaque that we demonstrated in that patient. And here's another area of ruptured plaque, very complex plaque, seen in this particular patient who basically responded well to this treatment and didn't develop a cardiac event. And so if we do a stent in this gentleman, we'll be faced with Plavix problems, which are significant. And you saw the patient we had that led to death from that in the past. So let's look at options. And so the options we have are perioperative statins, decreased risk, maximal medical therapy, maybe even looking at the plaque afterwards, bare metal stent, asymptomatic patient, then operate in 6 weeks, send him to Dr. Hauko's off-pump LAD and stent to the PDA. Or there's a, let's say this, and see if you agree, there's a low level of confidence in this data by the medical establishment of using cardiac CT and using the analytics that I've used. An aggressive treatment is not warranted, does not fit guidelines, not current standard of care, therefore proceed with surgery, surveillance, and stent if symptoms. Give diltiazem and propafenone with sips of water to avoid atrial fibrillation. So given that scenario, let's see what happened. And so you know what happened. We did change the patient to coming to Memorial, which is being established as a boutique hospital in the HCA, 169 hospitals in the United States. We did assign a nurse navigator. We did ask anesthesia to be on alert of this patient coming through. We did read the study as LAD ruptured plaque, D1. After D1, 63% stenosis, abnormal FFR surrogates, 50% mid-PDA lesion. We have information on the necrotic core of the stenosis as well as the plaque. Normal circumflex. We said risk of acute cardiac event with hip surgery is high because of vigorous systemic platelet activation, secondary to venous embolic debris, activation of Hagman factor, etc., etc. And recommend anesthesia and surgery alert, post-op EKG, troponins, nurse navigator to follow patient closely at home and by phone. And successful surgery, patient went home, chest pain, nurse navigator picked up on it. We brought the patient to Tampa General and put a stent in. So we didn't prevent the event. What we did prevent the disaster that could have happened, as in scenario 1. So let's go look. What's scenario 3? And scenario 3 is a newly thought out concept, and let's look at that. Scenario 3. Same information, same program, same information on the patient, but we've got cognitive computing. Watson detects asymptomatic ruptured high-risk coronary plaque in the Widowmaker artery. If we're going to read a headline, that's the headline that would be the news in the doctor's lounge. Well, this is coming from Watson. This is coming from the computer that won at Jeopardy, beat the biggest Jeopardy winners, won the Grandmaster at chess, and recently won, not this one, but another cognitive computer won at Go. So what happens? Well, there's very complex language parsing, color coding, and complex informational data going into algorithms that develops in Watson to identify parts of speech, parsing them, and coming up with information that's actually speech-driven. And so, and these are key words that I've used in this particular case of ruptured plaque, pre-op, hip replacement, platelets, activation, thrombosis, post-hip surgery, major adverse cardiac event, and hip surgery. And so let's look and see how this reads in a children's word picture language. And let's go to Watson having 10,000 plaque pictures, or Watson perhaps being programmed with build-a-plaque language, where we have 3 basic components that we can build any plaque with. Actually 4, because I got an ellipsoid here. So 4, including a circle and ellipsoid. And we can actually interrelate the words, but perhaps we can interrelate the pictures and have a stored, curated LAD proximal plaques that we relate in terms of composition, morphology, and function, and how we can join those with the vocabulary of stored information with our new plaques that we've observed in this patient. And so with that, we have the plaque analysis database as before, with the ruptured plaque as before, with the same blood flow analogies that you saw, with the same FFR correlates, curating the information that's supplied to Watson, looking at previous successful outcomes without MACE, looking at Plavix problems, prior experience with hip bleeding, and then data curating Watson to come up with these observations, concluding that ruptured plaque and platelet reactivity equals acute coronary syndrome, acute coronary activation. Watson has high credibility, therefore action taken in this case, and therefore a different conclusion, and deferring hip replacement for bare metal stent to the LAD are off-pump Lima. And here's a picture, here's the lesion, and here's the fixin, and concluding that, you know, wait a month after bare metal stent insertion, patient received anti-arrhythmic inhibition medication perioperatively to prevent atrial fibrillation, and surgery went well and was uncomplicated. Thanks, Watson. And so that concludes our conference today. Thank you so much for attending, and I wanted to give you some idea of what some of our thought products, our thought ideas have been, and what we've been working on lately. So hope to see you soon, and let's take a minute to chat. I think Largo has left.